I also appreciate your efforts to get everybody back in. It's always a challenge with this second panel of the day. So good morning, everyone. I'm Murray Ross with Kaiser Permanente, and I'm pleased to be chairing this session with the grandiose title of National Policy Issues and Political Implications of the Affordable Care Act. When Paul and Margaret and I were discussing this session back last fall, we actually do plan these things out more than a couple weeks in advance. Everything that was in the news those days related to government shutdowns and technological glitches with the federal government and things that you've read about. And so we wanted to basically create a range that was as wide as possible to allow people to cover whatever would be relevant by the time we rolled forward into February. Once we got as inclusive a title as we could manage, then we realized we were going to need to assemble a dream team to cover all the possible topics, and we did. I'll introduce them shortly, but all of our speakers for this session have been here before, but they have never all been here at the same time. So as a moderator, I really just have two jobs. One was to make sure that they each took a different flight to get here. And then to make sure that everyone, and in particular Joe, stays on time. So we have time for questions and answers. We're going to change the order up slightly from what's printed in your brochures. We're going to start with Elizabeth Fowler. Liz Fowler is Vice President of Global Health Policy at Johnson & Johnson. She joined J&J from the White House, where she was Special Assistant to the President for HealthCare and Economic Policy at the National Economic Council. During the run-up to health reform, she served as Chief Health Counsel to Senate Finance Committee Chairman Max Baucus, who's now Ambassador to China. Yes, I should know that. And she has a long and storied career in Washington, and without further ado, I will hand the podium to her.
Well, thank you very much to Paul and Margaret for inviting me back. I think I've been here, I was trying to count maybe 6 times, and each time wearing a slightly different hat, as Murray has suggested. But I've enjoyed it each time, and this year I'm here. I'm now at Johnson & Johnson. I'm speaking on my own behalf and not on behalf of the company, but happy to provide my view on where things stand and what's ahead. And just a reminder that where we were before health reform passed was a healthcare system that wasn't performing all that well. Health insurance premiums were rising. We've talked a little bit about how much they're rising after reform, but just remember that at least for small businesses before health reform, small businesses were seeing double-digit increases for the last decade before leading up to health reform. We saw family premiums for employer-sponsored coverage increasing, doubling over 10 years, and fewer employers were offering coverage. Healthcare as a percent of the economy was increasing in the 10 years leading up to health reform from 14% to 18% of GDP, and we were spending and still do spend almost twice as much on a percent of GDP basis and as a per capita amount than any other country in the world. And yet what we were getting from that was a healthcare system that wasn't performing as well as it could be considering the money that we were spending. We lagged on infant mortality, ranking just below the Slovak Republic and above Chile. Our obesity rate is the highest in OECD countries. And health system performance, one statistic that a lot of us working on the legislation would cite when talking about the need for health reform is the study by Beth McGlynn that said that for people with diabetes, when they go in for care, they receive recommended care 50% of the time. And so for all that we were spending, we weren't getting our money's worth. And for that reason, Congress and the new president took up health reform. Just a couple more slides to illustrate that point. Percent of health spending as a percent of GDP compared to other industrialized countries. This is from the Commonwealth Fund for the latest data that are available. And then this chart I borrowed from a colleague talking about health system performance rating. A number of ratings regarding quality of care, access, efficiency, equity, and long healthy and productive lives. The highest ranking highest third are in green, middle third in yellow, and the bottom third in red or pink, I guess. And the U.S., we are either yellow or red in all of the rankings, and then at the very bottom is the per capita spending. So again, just driving home the point that, that we had a lot of work to do. And frankly, for a lot of the members of Congress who worked on health reform, it really wasn't just about covering the uninsured. It was also about trying to improve the health system performance and also trying to reduce the rate of increase in costs. Let's not forget what is in the Affordable Care Act, and many of you probably know this better than I do at this point, but if I were asked to talk about the most important aspects of the ACA, first I would point to coverage, and I think the main point here is that the ACA expanded on the system we already had. It did not replace the system that we had in place. We had a complicated health system. We did not replace it with something new. Instead, we covered the uninsured through Medicaid for the very low income and through tax credits for private insurance for middle income. A focus on transparency intended to create markets that are more competitive. In theory, you can shop for coverage on exchanges based on benefits, cost and quality. Insurance market reforms, many of the reforms were intended to make the system more fair and more accountable. And I always point to my mother, who was right in the period before health reform. My parents retired, they moved to Las Vegas. My father had Medicare. My mother didn't have retiree coverage that followed them from where they lived. And so she went to buy insurance in the individual market and could not find an insurer who would sell her a product due to a pre-existing condition. She was 62 years old. She went back to work as a gate agent at US Air for $8 an hour just for health insurance on a part-time basis. My father was a doctor. They saved plenty of money. They could afford it. They were willing to pay a lot of money for health insurance. Nobody would sell her a policy. So I think that's one of the things we have to remember when we think about health reform. The other provisions, and some of these we talked about in the earlier panel about the minimum loss ratio, the medical loss ratio that says insurers have to spend at least 80% in the fully insured market of premiums collected on actual medical benefits or quality improvements. If they don't, they've got to rebate that money back to policyholders. In the first year alone, you would think that surely 80% was going towards medical care, but $1.2 billion was refunded back to people that was not used for medical care and was spent more on administrative costs. So I think keeping that in mind is also important. There was a strong emphasis on administrative simplification, trying to move to standardized electronic formats, and efforts to reduce waste, fraud, and abuse, high penalties for fraud, better coordination between the private sector and the public sector. When providers are committing fraud in the Medicare program, often they're doing the same in the private system, so the two systems are talking to each other now in a way that's, I think, going to lead to less fraud and abuse in the system. Delivery system reform, really, and we can talk further about this, but many of you are living this more than me, incentives for quality improvement and delivery system reform, and really trying to get at some of those inefficiencies in the system. And then a focus on prevention and wellness, a requirement for all plans to cover preventive services at first dollar, and new incentives for employers to adopt wellness programs. Employers can vary premiums based on participation in wellness programs up to 30%. This was something that the employer community pushed for very hard in the law. And just to reiterate some of the health insurance reforms, guaranteed issue, no coverage denials or rescissions. So my mother can, well, she's in Medicare now, but could buy insurance if she went to the market to buy it. She couldn't be turned down. She couldn't be excluded for her pre-existing condition or subject to medical underwriting. Premiums only vary by age, smoking status, geography, and family size. I think the interplay between premiums increasing and what's happening in the different markets probably has a lot to do with where your market was before reform and where it was after. Several states had already adopted many of these reforms, and actually premiums were higher in states like New Jersey and New York, where they might actually see a decrease in states that did not regulate their markets as much. and California being one of them, these factors make a big difference in terms of where premiums land post-reform. Requirement for essential health benefits. This is minimum coverage that counts for individuals. There can't be discrimination based on the way benefits are designed to discriminate against people with conditions. No annual or lifetime limits on benefits. And then limits that on policies that impose cost sharing. There's requirements for the standardized metal tiers, as we call them, an annual cap on cost sharing, which is playing out differently depending on the in-network, out-of-network issue, and then, as I mentioned, preventive care with no cost sharing. So what's happening in the marketplaces, as we've all seen, and you've seen this chart many times, so I won't go through it in great detail, but about half the states are not running their own exchange. 27, more than half the states, have a federally facilitated exchange. And the implications, I think, looking at what's available through these new marketplaces and in the states, some of the early IT problems combined with premiums and high cost sharing, which we've talked about, could mean lower than expected enrollment. Some of the narrow networks, I think, are a really important factor that we really need to consider, and I think this will be studied for years to come. I was on a panel with the head of the for-profit hospitals in Washington, and it was on healthcare transformation. And what was we were all asked at the end of the panel, what's the most important, the most transformative aspect of the ACA that's going to change the way that healthcare is delivered in this country? And I gave some fluffy answer about ACOs and shared savings. And the head of the hospital association said, narrow networks. That is the most transformative thing in the ACA, that if people get used to it and it's actually becomes an accepted factor in these exchanges, that we think that this could have implications on the employer markets as well. The same goes for tight formularies, which we're paying attention to also. For example, Vermont has cost sharing of 50% for non-preferred drugs. So that's another trend, I think, that the pharmaceutical industry is watching very closely. Again, just like the narrow networks, if this becomes the norm and it starts impacting the employer market, it has implications for not just coverage, but also costs in the long run. On the state Medicaid expansions, half the states at this point aren't expanding. When I wrote the slides, I put that Arkansas was the first to propose using federal Medicaid funds to buy private coverage. This is a new approach that Michigan and Iowa are following and Pennsylvania is considering. And of course, 2 days ago, the House of Representatives in Arkansas rejected that approach. So not only do we not want the Medicaid expansion, we also don't want to use the dollars to buy private coverage. We don't have an alternative. We just don't want any part to do with Obamacare or the ACA. Arkansas is obviously one of the states with higher uninsured, and I'm not sure what the solution is if you don't believe that they shouldn't get public or private coverage. The implications, of course, for the industries that contributed to the ACA and agreed to sign on in exchange for the higher coverage, like the hospital industry that agreed to $155 billion in cuts in exchange for covering the uninsured, the pharmaceutical industry who agreed to $80 billion worth of cuts and other contributions in order to have more customers buying their products. The lack of expansion obviously limits the upside of all this new coverage. Delivery system reforms, and since I got the 10-minute warning, I'll skip through these, particularly since many of you in this audience probably are living these much more than I am. And so what I will just say is that in considering the drafting of the ACA, those of us working on put the legislation in Congress, we looked around for all the best ideas and what could be operationalized, what could CMS implement, what would make sense for the Medicare program, did as much as we could. These are some of the areas of focus, and then set up the $10 billion in the Center for Medicare and Medicaid Innovation Fund as sort of a catch-all, both to capture some of the ideas that weren't quite ready for prime time, and also to learn from and expand the best ideas from the private sector, and that was the idea behind CMMI. Just to underscore the risk, the dollars at risk for hospitals, quite substantial when you start adding everything up. Hospitals are under an incredible amount of pressure Don't need to tell any of you that. Not only is it the new provisions, but it's also sequestration, the $15 billion in cuts last year for the physician payment cut to restore the cuts. So hospitals are undergoing quite a bit of pressure. More on accountable care organizations. There's a number of them out there now, 360 ACOs serving 5 million beneficiaries. If you add up the number of private sector ACOs, you get to over 500. At least in the Medicare program, they're distributed between urban and rural. This is not just an urban phenomenon. Some are hospital-led, but mostly physician-led, according to the CMS stats. And there's a role for retail pharmacies. You see Walgreens setting up ACOs and other retail pharmacies that now have a role in thinking about how they can be a player in healthcare and reduce costs and improve quality. Some of the early results, 32 pioneer ACOs successfully reported on quality measures. They had higher scores on patient experience surveys and generated $147 million in savings in the first year. The 9 of 23 ACOs had significantly lower spending relative to baseline, and half of the first-year ACOs, this is the first-year cohort, had lower spending than CMS had projected and earned savings of $126 million. 9 of the pioneer ACOs left the plan last year, but 7 of which transitioned to regular ACO programs. I think that the point of this is that the notion of shared savings, that if we do a better job of improving quality and reducing costs, there's something to be gained for both us and the system. And if this catches on, which we see, as I mentioned, in the private sector and in the public sector, it could really change the way we think about healthcare delivery, and particularly now seeing coordination among parties on in the provider space that maybe we hadn't thought about before. And actually, let me make one more point. You know, when I was on Capitol Hill, every year the pharmacists would come in and they'd say, you know, we want an extra fee for medication therapy management, that Medicare ought to be paying us to manage the drugs that patients are taking. And we thought that's a great idea, but the CBO costs, I'm looking, where's Jim? The CBO costs make it prohibitive, you know, really hard to justify. Now all these ACOs are doing the same thing, but because they're incentivized to do so because they gain. And so we don't have to pay for it as an extra fee and fee for service. We've provided the incentives for them to do it without having to add a new payment or a new benefit through Medicare, which I think is really important. Okay, 5 minutes. The cost of healthcare reform, this is not entirely a full picture, and I'm looking at Jim if he's going to start bouncing up and down and raising his hand. I just wanted to give you an idea of where the money came from and where it went in healthcare reform, because there's a lot of confusion about this. So about $938 billion went towards coverage, some improvements in Medicare, Medicaid worth about $75 billion. Where it came from was roughly half from new revenues. That included the Cadillac tax, the taxes on drug and device manufacturers, on health insurers, a new Medicare tax on high earners, and then some non-health related provisions. And then a lot of the savings came from Medicare and Medicaid, many of which were agreed to by the industries who, again, had something to gain from covering the uninsured. But I just provide this just as an illustration to give you some picture of the overall spending from Medicare, from the ACA. And the overall picture, and Jim made this point in his remarks, and he had a better chart that was updated. So this is the old chart, again, from 2010. But the point is that the trajectory, the bottom line, this was the score from 2010. The line shows that healthcare reform reduces the federal deficit. It doesn't increase it. So you might not have liked the way that the new coverage was paid for, but the fact is that it was paid for, and overall the impact is, in the first 10 years, reduces the federal deficit by $150 billion, which CBO just confirmed in Jim's remarks, and even greater in the second decade. So a few more points. National healthcare spending is now at record low. The growth in health spending over the last 4 years, according to the National Health Expenditure data, this is the slowest rate on record in the 53-year history of collecting this data. Total health spending grew only 3.7% in 2012. This is the 4th year that it's been below 4%. Medicare is also at historic lows. the Medicare baseline has decreased by 15%, looking out 10 years since in the period 2010 to 2013, and 11%, or $785 billion over the 10-year period 2010 to 2020. The implications of that, for those of you who want to fix the SGR, the sustainable growth rate, the cost of doing that used to be $300 billion, and now it's about $120 billion for the same policy because the baseline has come down so much. That's how significant it is. Now, we don't really understand the reasons for the slowdown, which has, of course, become a political issue. Obviously, part of it is the recession and the sluggish recovery, but there's also potentially larger health system changes occurring. And that, I think, is going to play out over the next few years. It remains to be seen. Health spending will increase slightly this year as a result of the reduced coverage. And federal spending obviously will continue to, for healthcare, represents a fiscal challenge going forward. Okay, almost done. In terms of enrollment, and I just wanted to put a little bit of reality on some of the numbers you see. CBO's projections for 2014, these were made in May 2013, so they will update them, and the updated numbers will consider the IT issues and some of the recent Medicaid events. But last year, CBO was projecting that 9 million would be enrolled in 2014 in Medicare, in Medicaid and CHIP, 7 million newly covered through exchange plans, and then 2 million losing existing non-group coverage, with some of those enrolling in the exchange plans. HHS is saying 6.3 million enrolled in Medicaid and CHIP, 3.3 million, this is new from last week, selected an exchange plan, and then the 3.1 million young adults. But I think, according to new Bloomberg numbers, and this was looking at the previous exchange numbers, not the ones released last week, there's concern that new Medicaid enrollment is really only 1.7 million, that only 1 million of the exchange enrollees were previously uninsured. And you have to watch those numbers because if people don't pay their premiums, enrollment could be lower. So all of this has a lot of implications for the people that support the law and the people that paid into the law. So obviously something that we're all watching very closely. Another issue, and I think Jim covered this as well, so I won't go into too much detail, but basically, what is the impact of the ACA on the labor market? It's either a job killer or it's actually a job creator. 180-degree difference depending on which channel you watch for your news. You really have to, it's been really hard to separate out some of these issues. In my mind, the bigger questions, putting aside job killer versus job creator, the impact of delaying the employer obligations for mid-sized firms, I think is something to consider in terms of the implications. The 30-hour work week full-time is counted as 30 hours averaged over a month. And then what I have a particular interest in considering is the standards for employer coverage that must meet minimum value and affordability, which for retail and restaurant industry really has implications for the costs that they're spending on healthcare. A couple more slides and then I'll finish. And I think this is just to remind everyone that things aren't always perfect when they start out. In Medicaid, which was implemented in 1966, really only 6 states were signed up initially. 27 states followed more quickly. And of course, the last state to adopt Medicaid was in 1982. The hope is that eventually all states will sign on. Maybe it just won't be right away. And then also looking at Medicare Part D, when it was rolled out, rolled out in 2005 for enrollment in 2006, only 27% of seniors understood the law, and only 21% were in favor of the law. So I would like to just at least think that maybe there's something to be said for if you give it time and we can work out the glitches, it will be a success in the end. Some of the implementation challenges, and in my view, what's been bugging the system. First of all, tight implementation timeframes because of the way the law was passed. House passed a bill, Senate passed a bill. We were trying to conference them, and then Scott Brown got elected. We lost our 60th vote. House ended up passing the Senate bill, which was drafted in December 2009. Probably would have changed some of those implementation timeframes if we had had a chance to revisit them in conference. Scarce administrative funds. So in 2003, and I worked on the Medicare drug bill too, when I was also with the Senate Finance Committee, we set aside $1.5 billion to implement one benefit for one population in one program. For the ACA, the law set aside $1 billion for implementation of the whole law. So think about how starved the agencies have been for funding to try to get done what they needed to get done. It's a very complicated statute. If you think about why some of the IT issues happened, part of that is because of the way the law was written. And for example, if you recall, after Congressman from South Carolina stood up in the joint session of Congress when Obama was giving his address and when President Obama said, no illegal immigrant is going to get tax credits or Medicaid under the new law. He stood up and said, you lie, which put all this focus on undocumented immigrants. And so now you can't buy coverage in the exchange if you are not in this country legally. It's not a provision that I favor at all. I hope that someday we reconsider it. But what it means is that the exchange for everybody applying must now connect to Homeland Security and Social Security to verify legal status. Think about how complicated that is. So the law has made this a complication that just, I think, compounded some of the IT issues. And the reality is, and made this point, the decision was to build on our current system rather than replace it with a new one for obvious reasons, most of which were political. By building on a complicated system, you end up with a complicated system. So we didn't get rid of a lot of the complexity. I think, in my view, no single person was in charge of the IT build, which was an issue. We've also seen, obviously, well-funded and a fervent opposition, a lot of misinformation, which has led to a lot of public confusion, a lot of governors who aren't implementing, and then, of course, a late start in enrollment. So that's my collection of implementation challenges. I'll leave you with one chart, which is we've tried to pass health reform in this country for over 100 years. Starting in the early 1900s, when health insurance was excluded from the progressive platform. The New Deal took up Social Security but left HealthCare on the table. The closest we ever got was 45 to 50 in the Fair Deal. Labor was split. Unions were split as to whether health reform should be nationalized, and the AMA vigorously opposed it. Medicare, Medicaid, we decided to compromise and only cover part of the population. Obviously, this has been something that this country has tried to struggle with. I will say in my current job, I've had the opportunity to focus on global issues and have been traveling around the world and meeting with and learning about other countries' healthcare systems and meeting with government officials in many other countries. And everybody asks me, why is it so controversial? Why is this so difficult in the United States? Why is the government shutting down over healthcare? And it's really hard to explain to other countries. So as much as we're all in it and we all watch our favorite news shows, which either give you one perspective or the other, a lot of people around the world are watching and really, frankly, hoping that we succeed and that we get past a lot of the partisan bickering and move on to a system that's more fair and covers as many people as possible. So I will leave you with that. I have one more slide. I'll leave you with that.